Education Institute. I'd like to welcome you all to the webinar today titled Diabetic Ulcers, Identification and Treatment. This program is made possible by a grant from Shield Healthcare. This particular event has been created to provide an opportunity for education related to clinical topics that affect the wound care market today. WCEI continues to have one goal in mind: to improve the management of wounds and ostomy for patients across the nation. We currently support over 20,000 alumni through certification courses in wound care, diabetic wound care, ostomy, and nutrition wound care. In addition, WCEI hosts the annual Wild on Wounds National Conference held in Las Vegas. During that conference week in September, there's an opportunity for those who wish to become certified to attend a certification course and receive the WOW conference as a bonus. Details can be found at woundseminar.com. So before we jump into the webinar, I'd like to run through a few housekeeping items. For those of you that are interested in obtaining educational credit, you will receive an email from WCEI within 24 hours after the webinar with instructions on how to obtain your certificate, as well as how to view the recording of the webinar. Please be sure to check your spam folder. If you have not yet downloaded the handout for today's presentation from your confirmation email, you may do so now by clicking on the attachment in the sidebar under Handout. The actual CE presentation should last about 60 minutes, so if you have any questions, please feel free to enter them into the question box at any time. If time allows, we'll answer your questions at the end of the webinar. As a reminder, to receive educational credit for this webinar, you must be viewing the full presentation and the slides. No credits can be awarded for those who do audio only. The accrediting body for this program is on the screen now. You can also check WCEI.net to determine the approved CE provider based on your license type. The planners of this course have declared no relevant conflicts of interest that relate to this educational activity. OnCourse Learning guarantees this program is free from bias. And now I'd like to introduce today's speaker, Bill Richland. Bill's a licensed physical therapist and has experience in advanced wound care consultations in long-term care, outpatient, skilled rehabilitation, and home health. He's the owner of Infinitus LLC, a wound care solutions company, a speaker and independent contractor for Anacapa Technology, has served as a clinical instructor for physical therapy students. He's been the director of several large rehabilitation departments, and has been providing multidisciplinary wound care education to nurses and therapists for over 17 years. His expertise in diverse settings enhances his role as a clinical instructor. Bill has a dynamic and captivating teaching style that will keep your attention throughout the session. Welcome, Bill.
Thank you, Muriel. I appreciate that great introduction. Hello, everybody. Good afternoon to some. Good morning to others. This is going to be a great time. I'm really excited to present our topic on diabetic ulcers, the identification and treatment of them, because obviously these can be a very challenging wound that we deal with on a regular basis. So with no further ado, let's just dive right in. So what is a chronic wound? Well, we know it by many names. They're commonly called stubborn, complex, refractory, hard to heal, recalcitrant, difficult, you name it. We can come up with all different types of terms to call them. The problem is they're just a pain in our backside, aren't they? Now, by definition, when we look at a chronic wound, it's basically, technically, it's a wound that fails to proceed in any type of an orderly and timely manner through the healing process. It ultimately results in a durable closure. So what is failure then? What do you mean when a wound fails to heal, or when should we worry? Well, typically we should expect to see signs of healing within about 2 weeks. And the common signs we look for usually are some amount of decreased size, whether length, width, or depth, less exudate coming from the wound, or less necrotic tissue present in the wound bed. Those would be all good signs that the wound is moving in the proper direction that we want it to. Now, looking specifically at stats related to diabetic ulcers, these unfortunately are a little bit scary. It's said that with a diabetic ulcer, if it is not healed at least 50% in the first 4 weeks of treatment, there's only a 9% chance that it's going to heal within the next 3 months. That's scary. It said that diabetic ulcers occur in anywhere from 10 to 25% of patients with diabetes. So if we kind of ballpark that, that's literally about 1 in 6 diabetics are going to end up developing foot ulcers in their lifetime. Another scary statistic is it is said that a DFU is going to precede 84% of all of your lower leg amputations. So when you see an amputation or you see a DFU, there is a likelihood of high risk for amputation there. There is a 5-year mortality of patients with DFUs that is nearly 50%. I mean, that literally, when we think about it and look at the mortality risk of other diseases like some cancers, it's greater than those, greater than prostate, greater than breast cancer, colon, Hodgkin's disease. And from a financial perspective, it's even more scary. We're looking at just outpatient. It is said that a DFU over the course of 2 years is going to cost about $28,000, okay, for one DFU. Imagine if they have multiple wounds. So then that brings us to the question of what do we do and where do we start? Well, the first thing I like to share with my students is simply this. There are 2 fundamentals to healing. Those fundamentals are simply this: healthy patient, healthy wound environment. If you can accomplish those 2 fundamentals, you will have no problem healing the wound. The challenge, of course, is achieving those 2 fundamental things is not always so easy. Getting our patients to be healthy, looking at things like, their underlying medical diagnoses, their blood flow, their nutrition, all those things, their diet, all that stuff. Those are the big picture patient side of stuff. And then, of course, getting a healthy healing environment is a whole nother challenge, and where we have to manage that necrotic tissue, that bioburden, the exudate, and all the other issues that come at the local wound itself. So what we start with, of course, is number 1 is we have to identify what the proper etiology or cause of this wound is. Okay, there are literally, I like to talk also to my students when I teach the WCEI course. I give them a list of what I call the 6 basics to wound healing. And of course, one of those basics is removing the cause. That is fundamental, to healing. We got to get rid of the cause. And I'm going to be presenting on all those basics at the WOW conference for those of you in the future that decide to come into the WOW conference that Demuriel talked about earlier. So I'm going to be doing a presentation on those 6 foundational key fundamental basics to healing. But let's start with, first of all, we have to make sure we've got our etiology right. What is the true cause of this wound? And then, of course, secondly, we have to make sure we're picking appropriate treatment choices. We do not want to look at wound care with this, I'm going to throw mud against the wall until something finally sticks. That should not be how we approach wound care. We need to approach our wound care with some basic principles of, number 1, what's the rationale for this treatment? If we can't answer a good rationale for why we're doing something, we shouldn't probably be doing it. The second thing we should look at is there any evidence to support why we're doing this treatment? Okay? Doing treatments that have no evidence literally end up just being a big, large waste of time and money. Now, I also understand that, we know that there's a lot of times there isn't necessarily always good evidence about some treatments. So then the second thing is real simple. Let's use some common sense and some logic. Simply put, does 1 + 1 = 2? Okay, so that's kind of how we want to start. Nail down the cause and make sure we're picking good choices. And I like to tell my students is be methodical. When you approach treating a wound, okay, don't try to do everything at once because you can't effectively do that. You need to work through and prioritize the needs of the wound and work through those needs in a very methodical way, okay? And if you do that, you have a much better chance of seeing steady progression than, again, just kind of going at it and throwing everything at the wall, you know, everything but the kitchen sink, literally, and hoping that at some point something's going to work. So let's start by identifying the causes of diabetic ulcers. Now, we all know this is kind of a duh, kind of a no-brainer. We all know that ulcers don't just magically appear, okay? And with diabetic wounds, we know that it is rarely going to be caused by one thing, okay? There is typically, with most DFUs, we're looking at 2 or more causes that are going to be occurring concurrently, that are going to be resulting in this wound that we're dealing with. Probably the number one cause, of course, is neuropathy, okay? This is where the nerves have become so damaged the foot becomes insensate. And this is caused by the hyperglycemia, which actually attacks and it damages those nerves down in their feet, so they lose the ability to feel pressure. They can no longer feel pain. Now, unfortunately, diabetes is not the only cause of neuropathy. It's only about 1/3 of the time is neuropathy caused by diabetes. Other causes are things like alcoholism, Lyme's disease, chemotherapy. All these different things can also potentially cause neuropathy as well. But obviously, we're focusing today on the cause of diabetes. On top of that, it is said that up to 1/3 of our DFUs also result from having associated arterial disease. So on top of the fact that they don't have any feeling, they can't feel when they step on that thumbtack, they can't feel when they walk around with a stone in their shoe all day, or their grandson's little green army man. I literally had one of my students in my class tell me that story, where my other favorite one was the guy that walked around all day with his cell phone charger in his shoe. Now, I don't know about all y'all, but how does you not feel a cell phone charger? But whatever the case may be, that was an interesting case. But on top of that, as I mentioned, our patients also commonly suffer from arterial disease. And it's been shown in studies that for every 1% increase in their hemoglobin A1C, there is a corresponding 26% increased risk of peripheral arterial disease. So that means when it comes to DFUs, we actually can subtype them because they're not all just one or another. Sometimes they're a combination. So the basic subtypes are this. We have neuropathic ulcers. These are strictly patients that have developed diabetic neuropathy. They have no sensation, no pain, no pressure, okay? No blood flow issues at this point, just the neuropathy. Our second subtype, of course, is neuro-ischemic, and that's pretty self-explanatory. We have the neuropathy and we have underlying ischemic issues. And then lastly, you've got just strictly ischemic, okay? There are some diabetics who have yet to develop neuropathy at any significant level, but they do have underlying arterial disease. It is said that about 35% of patients of DFUs are neuropathic, about up to 50% are neuro-ischemic, and only about 15% fall into that strictly ischemic category. Infections are another cause. Our patients can suffer cuts and injuries to their feet. Well, of course, they don't practice good foot care. We know they're very common to not wear shoes like they should all the time, even though they can't feel anything. And any little small item or object can cause a cut. We also know that diabetics develop a skin condition called xerosis, okay, which is a very, it's a condition where their skin literally begins to crack, peel, and fissure. And when you've got the cuts or the cracks and the fissures, or worse, they get infected toenails, their bodies, because of their hyperglycemia, cannot fight infections well. Hyperglycemia, as we know, suppresses and impairs the lymphocyte function. So their bodies cannot mount an appropriate response to deal with that infection, and that ultimately then, of course, leads to a wound. Trauma, okay? It can be trauma from, again, stepping on an object, you know, cutting their foot, but one of the most common sources is their actual footwear. They're not wearing proper shoes, okay? They don't fit properly, because we'll get into this. We're going to talk about how there are structural changes and potential foot deformities that can occur, and they don't wear proper shoes. Well, those shoes, because they're too tight, don't fit proper, increase the risks of pressure, shearing, friction, and all those different forces can lead to ultimately a traumatic type of an injury, and we call it a DFU. Now, pressure strictly can be an issue as well. Now, I want to clarify the difference though, because we have pressure injuries, or what we used to know or call them as pressure ulcers, bed sores, and then we have diabetic wounds caused by pressure. The difference is simply this: with a pressure injury / bed sore, if you want to call it for layman's terms, those are caused by a low force pressure, okay, that is continuous and sustained over a long period of time, hours and hours and hours, till eventually that pressure leads to an occlusion of the capillaries that then leads to ischemia and ultimately tissue death. In the case of our diabetics, it is not low force continuous pressure. It is generally moderate to high force pressure that is repetitive, okay? That is why you see these most commonly on the plantar surface of the feet, because they're walking, which is a repetitive activity. And every time they walk, those changes in the structure of their feet, which sometimes are subtle where they don't even manifest as a significant visible foot deformity, but there is shifts in the metatarsal heads and loss of range of motion at different joints. And as they're walking, it's going to increase pressure over those certain areas. And that is done repetitively over and over and over again until it eventually traumatizes the wound. Of course, nail and foot deformities. What we're simply going to do is take those minor structural changes that occur initially when the intrinsic muscles atrophy and the supportive structures like the ligaments and tendons weaken and the bones get weaker and the bones start to shift in place, but they don't change the look of the foot in any significant manner. Well, now you take a foot deformity where you've got a pronounced area of deformity, okay, and a pronounced area of bony prominence, so to speak, and now you walk on that every day. And if they're not wearing, again, appropriate footwear to offload it, you are going to repetitively be hammering on that point day in and day out, step after step, okay? Nail deformities, okay? The one in the picture, but then there are other nail deformities where they literally grow and they're not managing their nails properly. They can literally grow right around the toes, start digging into the bottoms of the feet. There's all kinds of different nail deformities that can result in tissue trauma. Now, risk factors for developing DFUs, of course, are numerous. Okay, one, of course, is any patient who's had diabetes longer than 10 years. They're going to be significantly at risk for getting a DFU than somebody who's just first being diagnosed in the early stages of diabetes. Of course, those that chronically have their A1Cs greater than 7%. Having a previous ulcer is going to increase their risk by 36 times. Males, sorry guys, we are going to be at higher risk if we're diabetics, because it's been shown that females are less likely to develop or have a lower incidence of neuropathy and peripheral arterial disease in the lower extremities. There's other diabetic complications that can make things worse. We have things like retinopathy, which becomes a visual impairment, and that makes it easier to traumatize your feet because you not see where you're going, you're not checking your feet, you don't notice when there has been damage. Cardio issues can also stem from long-term diabetes. Renal problems can develop as well from chronic diabetes. I've already discussed the loss of protective sensation. Okay, again, these patients do not feel pain or pressure, so they are not going to feel when they step on something, walk on something, etc. altered biomechanics of the foot. I kind of alluded to that. And being a physical therapist, this, really hits home with me, because understanding that normal gait, our foot, ankles, toes, they have normal ranges of motion that are required, so that as we progress through the gait pattern from heel strike to toe off, that our foot moves properly. Okay, it bends and flexes in all the right places. Well, unfortunately, with diabetics, due to the structural changes, joints become rigid, bones break, literally bony deformities. It throws those biomechanics off. And when they try to walk, they don't have normal mechanics, and therefore changes their gait pattern and changes how the body absorbs that pressure that is incurred while you are walking. And of course, that then typically will result in the evidence of increased pressures, and that is usually seen by the formation of callus or hyperkeratotic tissue. Again, add a bony deformity to it, and it simply takes it and kicks it up a notch. Having decreased and absent pedal pulses simply indicates that our patient is likely has poor blood flow to their limb, which again is going to be a risk factor for getting wounds as well too. We already kind of discussed the severe nail pathologies that can develop in these patients. If there's any DWCs in the crowd here listening in today, I'm sure you remember all the different nail formations that went over in that DWC class. Plantar callus. Again, this is generally a result initially of those repetitive high plantar pressures. The thing is, the callus doesn't actually protect the area. According to the studies, it actually has the ability to increase the pressure over that area by an additional 30%. Now, I don't know about all y'all, I'm looking at that callus on that fifth metatarsal head area there, on that, I guess that would be the right foot. I'm thinking that bad boy is producing a far more than 30% if you're walking on that. But anyways, I digress. But again, you're looking at potentially an 11-fold increase in the risk of DFUs with the formation of calluses on their feet. And then comes some of them, again, other more obvious things, the age. The older we get, we don't heal like we used to. We don't recover from even minor traumas like we used to. So that increases the risk. Visual impairment, again, with age, retinopathy. Smoking, of course, is always going to be an issue. Okay, I read a study once. They said that smoking one cigarette can constrict the vascular system up to 30% for 1 hour. So imagine your patients that are out there smoking 1, 2, and 3 packs of cigarettes a day. Add to that any type of psychiatric illnesses, and again, that can lead to a whole other bag of issues that you have to deal with. Obesity, okay? Put simple, folks, more weight, more plantar pressure, okay? With every step that we take as an individual, you put about 2 times your body weight through the foot, and if there's a wound on it, through the wound at the same time as you basically transfer the weight from the heel through the toes in a normal gait pattern. So you take a 400-pound patient, that's 800 pounds. That's actually when that heel strikes the ground. Okay. On top of that, it said with a 400-pound patient, they are literally exceeding by 3 times the maximum skin elasticity with every step that they are taking. So with that in mind, let's move into now looking at some of the clinical characteristics that we are going to see with these different subtypes of diabetic ulcers, so we can distinguish between neuropathic, neuro-ischemic, and ischemic. So let's start first with our neuropathic ulcer, okay? These are going to be most commonly seen on the weight-bearing surfaces of the foot, okay, the plantar aspect. And most commonly the heel, the pads of the foot are where the metatarsal heads are, and at the bottoms of the toes. Why? These are going to be the areas when you are walking that are going to take the brunt of the force as you are going through normal gait from heel strike to toe off. Now, the wounds generally will present with a red granular appearance to them, okay? That's because they don't really have any blood flow issues. So blood flow to the wound is good, but they are going to have typically that callus formation around the edge, because before that ulcer, it was probably likely a calloused area in its entirety because of the repetitive pressures over that area. The wounds are painless, again, because of the neuropathy. Typically your edges of your wound margins are even, and they usually have a round or oblong shape to them, and most commonly they're going to be over one of those bony prominent areas that we've discussed. The feet are warm, again, because there really isn't any blood flow issues. Pulses are usually strong and bounding. The ABI is generally greater than 0.9 or the TBPI greater than 0.7. Now, I know I want to cover this real quick because I know some of you out there who've been through the WCEI course or the DWC course might be thinking, why are we talking about the ABI? Isn't that an unreliable test with diabetics? And yes, that is true. However, currently right now, the American Diabetes Association still considers the ABI to be the standard test to do. However, that doesn't make it the most reliable test. There is the potential, and of course it's not in every diabetic, but some will develop, as we've talked about in classes, that you can develop calcification of those arteries in the ankle. And if that is occurring, that of course is going to falsely elevate your ABI, giving it assuming that it's more close to normal when it isn't. That is why the most reliable test is the TBPI, but that's why those both numbers are on there, so I didn't want to create any confusion, wanted to give some explanation. Okay, they're going to present, of course, with neuropathy, which is that loss of sensation in their feet. With neuro-ischemic ulcers, now this location changes a bit. These are more commonly seen on the margins of the foot, like around that medial surface of the great toe, that first metatarsal phalangeal joint, or over the lateral aspect of the fifth metatarsal phalangeal joint, or what we call the pinky toe. They're also found on the tips of the toes and beneath the toenail beds. The wounds will typically present with a pale pink or yellow necrotic look to them. And again, because of the ischemic issues, we're not going to have that nice beefy red look to our tissue like we did with strictly neuropathic wounds. The wound margins will still remain even, usually round or oblong, and they can be over a bony prominence, but they don't necessarily always have to be. That's why callus may or may not always be present either, because it may not be on a surface that is necessarily subjected to these repetitive high plantar pressures. Exudate most commonly with these, though, will be minimal. Because of the poor blood flow, there's not a lot of fluid getting to the foot, therefore there's not going to be a lot of exudate. Your surrounding skin is generally going to have that kind of a thin, shiny, dry appearance to it. Pulses, again, absent or weak, which would be expected. The skin is cool and pale or blanched in appearance. And again, this group does also have the peripheral neuropathy. With our ischemic foot ulcers, the location of these are generally seen in the toes, between the toes, over the tops of the toes or the phalangeal heads, and on that dorsal aspect of the foot. They generally present with yellow or black necrotic tissue, but there is a distinct, commonly a redness at the borders of the ulcer. There's usually a very distinct demarcation between the necrotic tissue and the surrounding viable tissue with these ischemic wounds. Again, because of the ischemia, that thin, shiny, dry skin, and those absent or weak pulses. Again, the feet and legs are very cool to the touch. The skin has a pale or mottled appearance to it. However, they will experience pain. They do not have any neuropathy. So these patients are generally in a significant amount of pain because of their ischemic disease. Now, there are numerous different systems out there that are used for classifying diabetic foot ulcers. The most widely used, of course, is known as the Wagner. However, the most descriptive system is the University of Texas Diabetic Foot Classification System. These are used for two primary reasons: reimbursement and to create a common language amongst healthcare practitioners when we are discussing our patients with DFUs. Now, the Megget Wagner, as I said, is the most commonly used one out there. It's also known as simply just the Wagner scale. All right. The grading of it is simply based on the most severe level of tissue that is involved and damaged, and it looks at three features: the depth of the wound, is there infection, or worse, gangrene. So that now brings us to talking about prevention and treatment of diabetic ulcers. So looking at the basic standard clinical practice guidelines out there, again, according to the American Diabetes Association, all individuals with diabetes should be at a minimum getting an annual foot exam. And that exam should include a very comprehensive assessment. It needs to be looking at the protective sensation. So a lot of times they use the Semmes-Weinstein monofilament test, is one of the most common and easiest tests to check for presence of protective sensation or loss of. Foot structure and biomechanics. Okay, this is imperative. This is why, again, commonly I do, in my personal opinion, is highly recommend that your diabetics, part of that screening process needs to be evaluation by a physical therapist. Somebody who has the training to know what normal foot structure is and what the normal range of motions and biomechanics are. So they can not only do a hands-on assessment of the foot, but they can also do a gait analysis. Just watching that patient walk up and down the hallway gives us a really good idea of what's happening. We need to assess their vascular status, whether we're using the ABI, TBPIs, or LOIs. There's another test that's out there as well too. And then of course we need to do a good look at their skin integrity. Another thing to look at is skin temperatures. It is a normal thing would be about a 3-degree difference, okay, at most, okay, from a corresponding area on one foot to the other. That would indicate really nothing of significance there to have about a 3-degree discrepancy. However, warmer areas, when you get into 4 or more, this generally can indicate inflammation that's occurring in the tissue. Now, the underlying cause we may not know immediately. It could be infection, could be a fracture, they could have developed Charcot's osteoarthropathy, or just soft tissue trauma. Can all lead to inflammatory responses, which is going to significantly, of course, elevate skin temperatures. Now, if they've got underlying limb ischemia, we're going to see those temperatures lower than typical normal temperatures would be. We may see it on a regional area. It may be just localized to a certain part of the foot. And you may or may not see that difference from side to side, depending on how significant the ischemia is bilaterally, okay? But a good thing to do when you do skin temperatures is you can use skin temperatures to map out if there is an unequal vascular supply. By taking temperature measurements proximal and distal to the wound, it can give you an idea of where the blood flow has been impaired and where it is closer to normal. Now, assessing it is usually recommended to use some type of an infrared dermal thermometer. Now, the sad and downside to this, of course, is these are not cheap. You're looking typically about $700+ for one of these fancy infrared dermal thermometers. But there is an alternative. The non-contact infrared thermometers that you can pick up at your local hardware store are literally just as good. And you can pick these bad boys up for typically about $50 to $100, which is significantly lower in cost. Easy tool to add into your diabetic foot screening kit. Now, once you're starting to identify different high-risk conditions with your diabetic patients, that means that we are going to have to conduct more frequent exams with them. And generally, that means probably at least biannually. We got to get away from just once a year. Now we might need to bring them in at least twice a year or potentially even more frequently if we figure the situation requires that. And every inspection, or I should say every visit, should include a visual inspection of that foot. Okay? Don't just ask them and talk about how their diabetes control is. And if somebody needs to be looking that foot and give it a thorough once over to make sure there are no issues or if new issues have developed. Now, the essentials, of course, in DFU management are simply this. First and foremost, kind of goes back to my fundamentals of wound healing, healthy patient, healthy wound environment, is we've got to treat that underlying disease process, okay? We've got to remove the cause, okay? If we do not effectively deal with the underlying disease, we're not going to see a lot of success in healing these wounds. We also need to make sure that there is adequate blood flow to this wound as well, too. No blood flow, no healing, okay? That is a basic. Adequate tissue perfusions are not negotiable. Pressure offloading, back to kind of removing the cause again. A lot of times these wounds are going to be plantar located, okay, which means they are going to be subjected to repetitive pressures. So if we are not effectively offloading these wounds, it ain't going to matter what dressing you put on it, how well you control their diabetes. If they're going to keep walking on that every day, it's just going to stay there. And then, of course, we need to deal with the local wound care. Okay, dealing with the callus, the necrosis, infection control, exited, all that stuff. So let's start first with glucose control. This is, again, treating the underlying cause. We know that elevated blood sugars creates a negative effect on the healing process. It can decrease O2 to the tissues. We've already discussed how it damages nerves and the small vessels. The microcirculation can be affected by hyperglycemia as well, too. Okay? And of course, we already mentioned as well earlier how hyperglycemia will impair lymphocyte function and your body's ability to manage and eliminate the bacteria and microorganisms in that wound. The easiest way to control sugars, of course, is healthy eating. But that's easier said than done. We all know it, okay? It is very difficult for a lot of people to stick to a healthy nutritional program, okay? Because the not so good foods are generally less expensive, taste better, and easier access to them, okay? But it's going to be an essential. We have to teach our patients and encourage them that they need to eat a healthy balance of the appropriate macronutrients, proteins, fats, and yes, some carbs, okay? But we need to make sure what sources are these coming from. The goal, of course, is to keep that A1C less than 7%. It's very common that we see this persistent inflammatory state in our DFUs. And this is generally caused by the necrotic tissue or necrotic burden that we see initially in these wounds. It's not being managed effectively. Bacterial infections, MMPs, which is a short, nice abbreviation for matrix metalloproteinases, and there's debris left over. Let's call these advanced glycation end products. That is debris that's left over from this hyperglycemic state that our patients are in. Now, the best way to end the inflammatory state is, one, clean the wound. Okay, as long as your wound has debris, necrotic tissue, or excessive levels of bioburden in the wound, the body is going to naturally have an inflammatory response to that. And until it is clean, the wound is going to stay in an inflamed state. And remember, when you look at the phases of healing, hemostasis, inflammation, proliferation, maturation, no healing occurs during inflammation. That's the cleanup stage, okay? So what we need to do as clinicians is we need to intercede here with all different forms of debridement. Sharps at the foundation of it, of course, in my personal opinion, followed by regular either enzymatic or chemical debriders, good mechanical debridement, and of course promoting good autolytic debridement. You are going to clean these wounds up much quicker. And that's what we need to focus on initially. If your wound is necrotic, your first and foremost goal, how quickly can I get this wound clean using the methods I have? And use as many as you can. We also may need to control the exudate levels. And that simply then is a matter of picking proper dressings, good absorbative products, whether it's foams, specialty absorbatives, alginates, whatever product of choice that you decide as a clinician is going to best deal with the exudate. Sometimes even negative pressure wound therapy can be helpful in dealing with higher levels of exudate as well. Sometimes in this excessive exudate, we also have elevated MMPs, those matrix metalloproteinases. And the downside with these is they actually degrade the healthy collagen that your body is actually building to fill in the wound, okay? So they start eating up the good tissue, which basically kind of sends everything, it's like one step forward and two steps backward. Now, the use of collagen dressings, they sometimes literally can act as, I like to say, they're the sacrificial lamb, okay? We throw them out there for these MMPs to go after, which then they lay down their life in a way, so to speak, in order for the collagen your body's producing to stay healthy and intact and ultimately close that wound. We need to make sure that we're also dealing with any underlying medical conditions that also could contribute to the healing process. It is said that 70% of patients with diabetes have high blood pressure. So we need to make sure that is managed effectively. Okay? It is said that 65% of people with diabetes die from heart disease and stroke. So heart disease is an issue. Again, nutrition and obesity, they pretty much go hand in hand. Okay, obesity is a very common thing in diabetics, okay? So we need to get our patients on an appropriate nutrition program so one, they can lose the weight and get down to a much healthier, manageable weight so that they're not overloading their body just with their condition of the body or the amount of weight that they're carrying and the stuff we talked about earlier when you carry all that extra weight, but all the other secondary things that can come from obesity like decreased tissue perfusions, lower oxygen levels in the blood, etc. If renal failure is an issue, that also needs to be addressed as well too. Now, if one of the underlying conditions, of course, is blood flow issues, we need to look at what can we do to improve blood flow. Okay, there's a lot of different ways. We have obviously surgical interventions. There's also different meds out there where they may not be necessarily need to have surgical reconstruction yet, but we need to increase the microcirculation down in that foot. And there are drugs out there like Pleadol, your statins, and your ACE inhibitors, all can also play a role in helping to increase blood flow. But in severe cases, like with critical limb ischemia, when they've got severe peripheral arterial disease, we might have to unfortunately look at surgical reconstruction, like with a revascularization, or sometimes a simple angioplasty may be suitable and sufficient in order to correct the blood flow to get enough blood to that foot so that wound will heal. Obviously, we need to offload the wound, okay? And that's looking at it from a lot of different things. Number one, typically with our diabetic ulcers, especially our plantar surface wounds, they're gonna have that hyperkeratotic tissue around the rim or the callus, okay? One, that callus is gonna prevent epithelial migration. In order for epidermal cells to migrate across a wound and close it, they come from healthy epidermal cells. Well, callus is dead epidermis and skin. So until you remove that, you're not gonna get good reepithelialization. But when you've got that rim of callus around there, remember, that can raise the pressure up to 30% more. And if they're not properly offloading the entire area, that callus can also put pressure on the edges, which again is going to inhibit and impair healing as well too, maybe potentially even cause additional tissue damage. And this is where sharp debridement plays a key role, okay? That is why commonly it is considered to be the gold standard debridement technique, especially with diabetics, because we need to remove that dead tissue as quickly as we can, and we need to shave and pare that callus off of that peri wound. It may need to be done weekly or even more often or repeated as new necrotic tissue can form in the wound or callus can build up when they're not, again, effectively offloading. Now, the gold standard for offloading the ulcers in general is what they call the total contact cast, okay? This is a casting system that all clinicians can be trained to do. It's not just done by doctors. Nurses can be trained to apply these, therapists, etc. Okay? It's a simple casting system that's really easy to do, but it has a very excellent ability in reducing the pressure over the ulcer site, but it still allows the patient to remain ambulatory. Again, from what I've read in the studies, it is said that those, when applied properly, it can reduce the pressure over the ulcer by 84 to 92%, even while they're walking. And why it's the gold standard is because studies have shown 73 to 100% complete healing when using TCs in diabetic ulcers within 3 to 6 weeks, okay? Now understand, it is not, the TC is not the holy grail thing. All you gotta do is get a TCC and it's all done. No, you have to deal with all the basics. The wound's gotta be nice and healthy and clean. You're treating the underlying medical condition. All the factors have to be there. But this is just how important that offloading is, okay? Because if you get all the other factors in place, but they keep walking on it, you're not gonna see this wound heal, okay? Definitely not in 3 to 6 weeks. Now, the other reason why, the two main reasons why the TCC is so effective, one I already mentioned, 84 to 92% reduction of pressure over the ulcer site. Second reason, it has a really high adherence rate. That's right, folks. They can't really take it off, okay? And that is what increases the success of this particular product. Now, unfortunately, we also know that not everybody's going to be a candidate for a TCC. So in those cases, we're gonna have to look at orthotics, adaptive equipment or assistive devices for ambulation, shoes that are modified for offloading the patient's ulcers and stuff like that. The downside to these other offloading devices is the adherence rates decrease significantly because the patient is able to remove them at their leisure, and then it's up to them to put them back on as well. We want to watch for infections, okay? Again, diabetics are always going to be high risk for infection because if they're hyperglycemic, it's going to impair their body's ability to kill bacteria and eliminate it. And very commonly, the signs of infection are often masked, so to speak, in diabetic wounds, where they don't necessarily show all the typical inflammatory responses you would expect to see, the pain, the redness, the swelling, etc. So in dealing with diabetic foot infections, we want to use very aggressive treatments and interventions, especially when the infections involve deep abscesses, bone and joint involvement, if there's crepitus, substantial necrosis, or worse, gangrene. And when we mean by aggressive, because of the depth of these infections in the tissue, it is going to require oral and IV antibiotics in order to succeed at that. However, keep in mind, though, that because of blood flow issues, those oral and IV antibiotics may not have as big of an impact at the wound itself, okay? And therefore, it's also very recommended that you treat the infections topically as well, too, okay? Don't just try to hit it from one side. Hit it from both, systemically and topically if necessary. Okay, and I always encourage, always hit it topically, because we want to make sure that those, where it starts typically on the surface, doesn't go any further. One way to manage that local topical bacterial level is debridement. By debriding, you get rid of one of the main sources of the bacteria, the necrosis and other waste products in that wound and debris. That means debridement regularly and, of course, effectively cleaning your wounds with every dressing change. A clean wound is going to have a significantly lower risk of infection than a dirty wound is. And after 2 weeks, if you don't see improvement, obviously we're going to need to look at changing the treatment. There's that kind of that old 2-week rule. If you're not seeing results in 2 weeks, it's probably not working. Time to change the guy. Okay, it may require a reculture, and of course, when we say culture, we're talking tissue culture, i.e. punch biopsy. Do not waste your time with swab cultures. Swab cultures do not provide a quantitative analysis of the microorganism levels in the wound. All it does is capture the colonizers. It tells you everything that's growing in the wound, but it doesn't give you a quantitative analysis as to which one is the problem. Okay? It's actually documented out there that swab cultures have been an inappropriate tool for assessing wound microbiology on a quantitative basis since 1994. Okay? If we want to do a quantitative analysis, it needs to be a tissue culture via punch biopsy. Now, if it has improved, but it still looks to be infected, we just continue that treatment until the infection resolves. Now, that brings us to products we can use topically in order to deal with this, okay? I'm going to probably shake up some of your worlds today because, unfortunately, with a lot of these topical products, there is a lot of misunderstanding about how they work, and it's a combination of the reps from the products don't necessarily disclose all the details, and as clinicians, we're not doing our due diligence to research the product in depth. Okay, so let's start with silver dressings. Now, silver is a broad spectrum antimicrobial agent, has been proven over the centuries. High enough concentrations of silver will kill pretty much most microorganisms. The challenge is with silver dressing is the silver never leaves the dressing. Therefore, it only kills bacteria within the dressing. Please understand that, okay? There is no release of silver from the dressing into the wound, okay? Any bacteria that is drawn into the dressing or tries to transmit through the dressing will not make it, okay? But there is no silver that is released into the wound to kill the bacteria in the wound bed itself, okay? So these products are more for preventative measures, but they are not going to be used and cannot be used effectively to reduce the wound bioburden. Okay? It's real simple, folks. If the silver was to leave the dressing, the FDA would consider that a drug, and therefore these products would all have to go through FDA approval as drugs, not simply FDA clearance as a dressing. Okay? And also keep in mind, silver has no effect on biofilm. PVA foam. Any of these foams out there that you are seeing with gentian violet and methylene blue, I call it GVMB. Okay? GVMB are chemical dyes that have been used for years. They're old school back in the day where they actually used the physical dyes in the wound, but now they're impregnating them into dressing. They have a broad spectrum bactericidal, bacteriostatic effect, and can prevent the reestablishment of a biofilm once it's been removed. Again, these chemical dyes, the GVMB, do not leave the dressing. So that understand that they're only killing bacteria and preventing biofilm reformation inside the dressing. PHMB, that's just an abbreviation for a really long word called polyhexamethylene biguanide. It's just easier to say PHMB. PHMB is a broad spectrum antimicrobial agent, generally very effective against gram-positive and gram-negative. However, again, it only works within the dressing. So the bacteria have to come in contact with the dressing, or if it's in a cleanser or a gel product, it simply functions as a preservative agent within the cleanser or gel so bacteria cannot grow within it, okay? These gauzes are commonly seen with the gauze-based negative pressures, okay? But again, it kills bacteria within the dressing. Now, here's a product that actually has evidence and does reduce the bioburden in the dressing as well as within the wound, Cadexamer iodine dressings. Now, there's only 2 of them on the market today currently, and that's IotaZorb and IotaFlex. They're bacterial static in that they inhibit the growth, but they're also bactericidal. They've also shown to stimulate increased growth factor production and activation within the wound, and they have demonstrated the capabilities of penetrating the matrix of a biofilm to get to the underlying bacteria as well. Modified sodium hypochlorite. Okay, there are many sodium hypochlorite products out there or hypochlorous acid products on the market. The most common, of course, sodium hypochlorite, I think that most of us listening here are familiar with. It's good old Dakins. Been around since 1915. The challenge with Dakins is generally the most effective form of Dakins is, full strength, but it's also highly cytotoxic, okay? A product that's on the market today called Anicept Wound Cleanser and Gel is the only FDA cleared antimicrobial cleanser and gel on the market, okay? It is bactericidal, virucidal, fungicidal, and sporicidal, okay? And on top of that, it has been modified so that it is not cytotoxic. An added benefit to this product is sodium hypochlorite is a chemical debriding agent. So it can actually chemically debride necrotic tissue from the top down versus an enzyme, which of course, as we know, debrides from the bottom up. But again, this is a product that actually has clinical evidence that will reduce your bioburdens in the wound. Medical grade honey. Here's another one out there that's very popular. But just so we are aware of what this does, yes, honey has shown to have a broad spectrum antibacterial effects, and there's no risk of bacterial resistance. The challenge with honey is these products and the honey itself has only ever been tested in vitro. And unfortunately, there is no correlation between in vitro and wounds. Now, the upside to it is it may not be that antimicrobial you're thinking it is in the wound, but it does have an ability to reduce edema. It can lower the pH in the wound, which can create an environment that's hostile to bacterial growth. And it's also very effective at promoting autolytic debridement. So it is usually very commonly used to help expedite debridement in a wound as well too. So in considering our DFU dressing selection, moist wound healing is imperative. Okay, there's no role for dry wounds. Protect that wound from pressure, contamination, etc. It needs regular inspection. They generally don't recommend that you go more than 5 days between dressing changes typically. Try to stay away from tight and bulky bandages as there is the risk of, again, potentially increasing the pressure over the wound. Your adjunctive therapies, negative pressure, your regranics, biological wound coverings like your skin substitutes. These are like your Apligraph, your Dermagraph, Alloderm, Allograft, and hyperbarics. All very helpful and useful adjunctive therapies as long as all the basics are in place. Do not neglect the basics for adjunctive, because if your patient is malnourished, using any one of these modalities is going to do them no good because you can't heal a wound without proper nutrition. So why spend the money on negative pressure, skin substitutes, and hyperbarics if they're not even eating enough to even heal the wound? I'm sure you understand what I'm saying. So always put the basics in place first, and if they're not enough, we add to it the adjunctive therapies. And then lastly is patient education. Patients with a strong understanding of their disease are more likely to recover and not have repeated setbacks. So do a thorough job of educating your patients on the importance of their wound care, of controlling those blood sugars, of offloading, wearing that offloading device, being adherent. For preventative, make sure they're getting their foot care being done, being assessed once or twice a year at a minimum. And daily checks by somebody, a loved one or themselves, checking their feet. Proper foot care is essential for prevention. and of course, managing those underlying medical conditions with good health care. Now, there are a number of different tools, forms, and brochures available. There are details in your handouts of how you can access those, so I'm not going to get too much into that. And I believe with that, that brings us to the end. These references are all in the handout, so I am not going to read through them for you. I'm just going to click through them very quickly. I want to thank you all for being attentive, and I'm going to turn it back over to Demuriel.
Thank you, Bill, and thank you for such a great presentation today. This is the conclusion of the continuing education portion of this webinar course. But in this time, if you guys have any questions, please feel free to enter them into the question box now. Also, while we're waiting on some of these questions to come through, I'd like to ask you guys a poll question. Are you interested in learning more about wound care certification courses? Just let us know yes or no. We'll reach out to you and let you know what is available and how do you get wound care certified or diabetic wound care certified. And just let us know yes or no. Great, thanks guys. So we have a ton of questions, Bill. Let's see.
I'm shocked.
I'll read them out to you. All right, here's one. Where besides the foot can diabetic ulcers form? I know the foot is the most common area, but how often do they form elsewhere and where else?
That's a good question. Real simply, according to the International Diabetes Association, you can only have a diabetic ulcer below the ankle. So technically, they can only be on the foot. There is no other part of the body that you can get a diabetic wound. And that would fall under that classification of a diabetic foot ulcer. It has to be on the foot, plantar, dorsal, lateral, anywhere on there, as long as they have diabetes, and we can attribute the cause to something associated with diabetic issues.
So I guess that leads us to the next question. Diabetic patient with pressure injury from compression stocking on the dorsal surface, is that a diabetic ulcer or a pressure injury?
That's a very good question. Basically, what you would want to do in that case, because with a compression bandage, okay, you have that constant sustained pressure because it was wrapped too tightly. So unfortunately, that would be considered a pressure injury. Again, remember with diabetic ulcers, it's got to be that repetitive high plantar pressures, whereas with a compression wrap, it's not going to be a high force pressure. It's going to be a low force pressure, but it's on there for several hours or a day to where it leads to ischemia. So that unfortunately would fall under a pressure injury with, unfortunately, contributing effects from their diabetes, which would affect their healing long term.
Great. So how visually can you distinguish between a pressure ulcer and a diabetic ulcer, or arterial versus venous?
Just to distinguish between a diabetic versus pressure, again, the main thing is you may not visually necessarily be able to distinguish. That's why there are many factors that you have to look at when you're trying to determine etiology, okay? The main thing with a pressure injury is that you would have to show that something caused a continuous, sustained pressure over that particular area for a long enough period of time that it would lead to ischemia and tissue death. That is a pressure injury. Whereas diabetic, again, you could have it on the same area, okay? But diabetic is not going to come because they have constant pressure. It's these repetitive, high plantar pressures, underlying ischemic disease, and those types of things that you're going to be looking for. So it really is looking at what ultimately produced the tissue death or tissue damage. And that's where you have to do the best you can to discern, was it sustained pressure that lasted for hours and hours and hours and hours and hours, or was it this is an area that the pressure was more repetitive and due to their underlying unable to feel, poor blood flow, and this ultimately resulted tissue trauma. That would be the best way I can answer that question. As far as arterial and venous, obviously with venous disease, you're going to expect to see edema, okay? Versus with arterial disease, you're not going to see any edema. Venous will tend to be more medial on the lower leg, and arterial most commonly is going to be seen on the foot and potentially the lateral aspect of the lower leg. It's not as common to see arterial wounds really high on the lower leg, unless, of course, their blockage is really severe way up the limb. I hope that answers the question.
Yeah. Okay, so what are your thoughts to performing handheld Doppler instead of an ABI for a quick check of foot blood flow?
Well, in order to perform an ABI, you have to have a handheld Doppler. Okay, you cannot do an ABI without that. It is required to have an 8 to 9 megahertz handheld Doppler and a blood pressure cuff in order to do an ABI. Okay, so if you just do a handheld Doppler where all you're doing is sensing if there is, a pulse and a blood flow through the area, you can't really determine necessarily from that how good or how poor. I mean, you can get a sense that there might be impaired blood flow, but without doing a full complete test in ABI where you're comparing to different areas, it's really hard to make a differential diagnosis of, is there vascular arterial disease or not, just doing the Doppler part without doing the full test.
Got it. Okay, so will diabetic ulcers, I just lost the question. Will diabetic ulcers blanch or not blanch? Or does this play a part at all in diabetic ulcers?
I'm assuming they're referring to an area of intact skin, like with a pressure injury, a stage 1. Again, potentially, I mean, I've never dealt with too many because again, diabetic area, if you've got an area that's rubbing and it's inflamed, but there's no break in the skin, but when you're doing their foot inspection, you're like, wow, this is a spot here. You do your thermal, infrared non-kinetic thermal drying, you're like, it's a little warmer there, and you can also see some redness in the skin. But again, if it's just a natural inflammatory response at this point, it may blanch. So I don't know that that's necessarily a good key indicator. I mean, I would say that you could definitely have blanchable, quote unquote, erythema if there is a low grade inflammatory response, but no wound, even with the diabetic.
Thanks. So I think we have a couple more minutes for some questions, so I'll just keep going as they're coming in. As a home health nurse, how can I get the doctor at the wound care clinic to change their regimen if the wound isn't healing or is stalled?
I think that is a challenge that many of clinicians face out there, which is getting our prescribing clinicians to change. And again, it's just a matter of appealing to, if you're documenting that there's no progress, okay, in the wound for a certain period, generally a 2 to 3 week rule. Well, if it hasn't worked and there's been no progress in any of the signs of healing that I discussed earlier in the thing, like that's gotten smaller, there's not any less dead tissue, the exit levels haven't decreased, there's no real signs that the wound is moving towards healing, that to me should be common sense. Unfortunately, we deal a lot with a lot of prescribing clinicians are not well educated in wound care. And so they a lot of times have very limited options, because when you don't have a lot of training, you don't know a lot of options out there to treat with. You have, you open up your toolbox and there's only 3 or 4 treatment choices in there, and those are all you have available, So they're looking at, well, I can't change now. I've only got a couple other options to try, and I'm going to run out here quick because I've already tried 2 of them and I'm down to my last one and it's not working. So the best thing to do is present to them, well, if it's not progressing, can we, start with that. Lack of progress for about 2 to 3 weeks. If it hasn't worked for 2 to 3 weeks, it's not going to work again. It's not going to work any better in the future. So maybe it is also looking at what is also not being addressed. That's why I talked about the basics of healing. A lot of times we might have the right treatment, but the problem is it's the perfect local treatment, but we haven't addressed the other issues. there isn't good blood flow. Their nutrition is poor. Their blood sugars are all over the map. It doesn't matter what dressing or what treatment you're putting at the wound. If you're not treating the whole patient as well, your treatment isn't going to work either. So again, that's why you have to look at it from a bigger perspective. Is everything be addressed? And I'll be honest with you, a lot of times we are not doing the basics. Okay, those 6 basics I'm going to discuss at the WOW conference are not being covered a lot of times, and they're counting on their dressing or their local treatment to be the holy grail, without looking at all the other issues that are not being effectively managed as well.
Well, thanks so much, Bill. I think that's all the time that we have for questions. Again, thank you for a wonderful presentation. Thank you, everyone, for attending.
Yep.
And as a final reminder, you guys will receive an email within 24 hours with instructions on how to obtain your certificate of completion. Thanks again for attending, and have a great day.
Thanks, everybody.